final presentation in this session on mortality. We will be hearing from Karen Joynt Maddox, who is an associate professor of medicine and the co-director of the Center for Advancing Health Services Policy and Economics Research at Washington University. And she will be speaking to us today about shifting rural-urban incidence and outcomes of acute myocardial infarction in Medicare beneficiaries. Karen,
Great. Good morning. Can y'all hear me okay? Yeah? Okay. Well, I'm so sorry not to be there with you. I'm an Ann Arbor native, and it pains me to see all these people in my hometown without being able to be there. But I hope you're all having a wonderful meeting, and I'm glad to get to share a little bit of our work. I'd like to thank the folks on this slide, as you can see, for being an amazing team, particularly RJ Waken, who's there in the room somewhere. And we'll be talking about some of the sort of underpinnings of this work later in the day. I'd also like to thank John Su for introducing my topic quite effectively and making it easy for me to zip through some of the background of the study. So just quickly, I'd obviously like to acknowledge the funders of this particular work with all the rest of you in the room, I'm sure, and then disclose that we have other grant funding related to this topic, and that I have prior financial disclosures with Centene and work with JAMA. Okay, so as John so ably described, COVID was associated with major care disruptions across the country, including, of course, to cardiovascular care. And also, as he mentioned, though the drops in AMI during the pandemic were fairly well described, there then is a bit of a gap, actually, in sort of what happened as the system recovered. And certainly the longer term effects on incidence and outcomes are where we're all now starting to try to dig in and see what happened. In this presentation, I'd like to particularly focus on differences between urban and rural communities where we know that the strains were different. The strains in rural areas came later, and economic downturns were slower to recover in those areas as well. So it's sort of a different type of problem in rural areas that may have been less acute in the sense of sort of major volume in the first couple months of COVID, but that we suspect may have important longer term implications in terms of sort of the broader effects in those communities. So the objective of our study was to determine whether there were changes during and post-COVID in incidence, treatment, or outcomes for acute MI. And we used the CMS Virtual Research Data Center to analyze data for Medicare beneficiaries from 2018 to 2022. We've done it for fee-for-service and Medicare Advantage. I'm going to show you just the fee-for-service today. But I'll put a teaser in for what RJ will talk about later around some of the differences and comorbidities between the groups and why for now we've got just fee-for-service in this presentation. We defined AMI hospitalizations as ER, OBS, or inpatient stays with a primary STEMI or non-STEMI, or primary cardiogenic shock with a STEMI or non-STEMI diagnosis. We looked at quarterly index hospitalization rates normalized to quarters at risk. So people do come in and out of the fee-for-service program, either because they go to Medicare Advantage, they're newly enrolled, or because they die. So all of what I'm going to show takes that into account. And we looked at both in-hospital and post-discharge outcomes. And again, those post-discharge outcomes were normalized to the number of beneficiary days at risk. I'll say that's a little bit different than how Medicare, for example, reports say, 30-day readmission rates. This method takes into account the fact that people who have passed away are very unlikely to be readmitted. So our numbers are slightly different than you might have seen for some of those, but they're close. Hospital revisits are quantified as subsequent hospitalizations at any hospital, so it doesn't have to come back to the same facility. So to get right into the results, these are our patient characteristics. So this is, again, fee-for-service Medicare. So you see in the pre-pandemic, pandemic, and post-pandemic periods that our N is dropping. And I'll show you on the next slide what that looks like normalized to beneficiary days at risk. But a big chunk of that is that Medicare Advantage became much more prevalent over the study period. So we do have just fewer people at risk. But you can also see there's some pretty important shifts in who's in fee-for-service. So the proportion who are under 65 years of age has decreased from 13% to closer to 9% across the study period. The proportion that's white has gone up from about just over 79% to more like 81%. and the proportion dually enrolled in Medicaid down at the bottom has decreased from about 22% to about 18%. And those are consistent with other national data suggesting that a different group of folks are choosing Medicare Advantage than used to, particularly based on social risk. So these are plots of AMI incidence per beneficiary days at risk. So again, this takes into account the fact that the denominator is shifting to some degree. You can see STEMI on the left and non-STEMI on the right. And this is broken down by metropolitan in red, micropolitan in green, and rural in blue. And those are by CBSA. And you can see that overall, the incidence of AMI was sort of slightly decreasing prior to COVID. If you look at, obviously, the metropolitan line is the easiest to see because it's the most people. So the smoothest line down at the bottom, you can see the incidence of acute MI is dropping. There's obviously a dip, particularly at the time of COVID. You can see it easier in the non-STEMI curve. I'm not sure if you can see my cursor or not, but in the non-STEMI curve, you can see the dip a little bit better. And then it appears to sort of continue on a bit of a downward trend thereafter. When we look at in-hospital complications and procedures that took place during this time, again, with the same N at the top of our folks who have had an acute MI, we see the proportion with STEMI and non-STEMI is about the same over time. There was some concern there was an increase in STEMI during COVID, particularly in those few weeks where only people who were really, really sick were coming in, and that sort of washed out over the course of the first couple of years of the pandemic. Increase in folks coming in cardiogenic shock that goes across the entire study period. Some of this could be coding, but certainly we do see that going up. In-hospital mortality, 6.9% to 7.4% to 7.1%. So a bit of a peak during the pandemic, as had previously been noted in some other studies. And then maybe less relevant to some of the outcome data, but certainly very relevant for broader health policy questions, a marked and sustained decrease in the proportion of patients being discharged to skilled nursing, going from 11.5% down to 8%, and persisting there post-COVID, in part due to a decrease in supply and availability in the nursing home industry, which is the only one to have still not recovered fully in terms of staffing and capacity. So post-discharge clinical outcomes, and this is the same sort of setup here, raw outcomes. Any acute care revisit, so that's including ED visits or inpatient hospitalizations in the first 30 days, goes from 0.39 down to 0.36. 30-day outcomes, this is not including the death and the index hospitalization, so post-discharge death, 5.4 up to 5.9 and then back down to 5.2. And then you see at 90 days sort of a similar pattern, a sustained decrease in revisits post-hospitalization and a peak that goes back down in death. So this slide hopefully is big enough in the room that you can see it, but this is the forest plots of the models that then take all of those data points that I just showed you, break it into urban or metro, micro, and rural, and account for a number of other factors in the modeling. And so you can see on the left-hand side here, this is what we consider pandemic versus pre-pandemic. And you can see in-hospital death up across the board, perhaps a little more notable for micro and rural populations than metro. Discharge to SNF way down for everybody. 90-day mortality up for everybody, but again, more pronounced in the micro and rural communities. Here's our 90-day ED visits. So down overall, particularly in the metro areas, and 90-day rehospitalization down for everyone, actually maybe a little bit more in micro and rural. If we then move out to the sort of quote unquote post-pandemic, I gotta sneeze, hold on. Sorry. Post-pandemic, you can see that the in-hospital death has basically returned to baseline. It actually is a little below baseline or nudging below baseline for metro, but stays up for micro and rural. SNF discharge still way down. 90-day mortality clearly down overall and among urban folks, but still up for micro and rural. 90-day ED visits sort of trending down across the board, but not quite meeting statistical significance in some of these folks. And then 90-day rehospitalizations down across the board. So in summary, during the pandemic, we saw AMI incidence decline, but then continued on what appears to be close to its slightly downward trend that had been existing pre-pandemic into the post-pandemic period. During the pandemic, mortality was higher, but readmissions were lower, particularly in rural areas. And post-pandemic, mortality has recovered among urban but not rural beneficiaries, and readmissions remain down across geographies. This is actually the first time readmissions have dropped, despite 10 years plus of a program designed to reduce readmissions, interestingly. So there's some obvious limitations to our project. It's only Medicare. And so we have few insights into how this might affect younger adults, except for those who may be on Medicare due to a disability. This is only fee for service for now. We account for days at risk and comorbidities, but obviously with any shift in the denominator, unmeasured confounding is possible. And the analyses can account for COVID only where there's a claim. So in obviously the sort of later parts of the pandemic, there were many cases of COVID with no claim because they weren't treated with sort of a specific medical encounter. So in conclusion, COVID was associated with meaningful shifts in mortality and readmissions for Medicare beneficiaries with acute MI. I think in the long run, we thought care disruption was going to be the big player here. I think seeing how durable some of these changes are, it's really likely due to differences in care seeking and potentially differences in underlying patterns of illness. But the combination of increased mortality and decreased hospitalization suggests that some of these new patterns of utilization may not be optimal. And though we've talked for a long time about being good to keep people sort of away from the emergency department, if you need emergency care, you should be there. And I think some of these findings, right, with some of the other combined with some of the other work that we've done, sort of raises some concern that some of our newer utilization patterns may actually reflect an inappropriate decrease in access and utilization for some of these conditions. So I'll stop there and I look forward to the discussion.